Hey, what's up, guys? This is Sasank Med. So, I am an incoming PGY1 internal medicine resident, and I'm going to be trying to cover some topics every day on internal medicine. So, I'm just trying to get ready for intern year. So, what I'm doing is I'm going to be utilizing MGH and things like that to try and cover some high yield topics. So, today we're going to be talking about chest pain. So, chest pain is a very vague complaint when a patient comes to the ED, and the ED physician usually takes care of most of this. But as an internal medicine resident, sometimes you're going to have to do the full H&P. So, it's important to know what conditions could present with chest pain. This is not an exhaustive list, but I'm going to talk about some of the common conditions and how to rule them in or out. Uh, I'm just going to list out the most common causes. So, stable angina, acute coronary syndrome, acute aortic syndromes, acute pericarditis, pulmonary embolism, pneumothorax, pneumonia, pneumonitis. There's other causes, which I briefly am going to talk about, like costochondritis, GERD, esophageal spasm, and panic attack, and stuff like that. So, what I'm going to do is I'm going to talk about each condition, the etiology, the history, and the physical exam. So stable angina acute coronary syndrome, the etiology is basically a reversible or irreversible ischemia to your coronary arteries. Uh, for the history, when you ask the patient, you should ask about characteristics and duration of the symptoms. So ask them about what the chest pain feels like, whether it's present throughout the day or comes in and out, any associated symptoms, any provoking factors, any cardiovascular disease risk factors, such as family history of major adverse coronary events, or otherwise known as MACE. So characteristics of chest pain. So is the pain retrosternal, like below the sternal bone? Is it dull pressure-like chest pain with radiation to the arm, neck, jaw, or back? Is it exertional or stress-related? Associated symptoms that makes stable angina or acute coronary syndrome more likely, or dyspnea, difficulty breathing, diaphoresis or sweating, nausea, syncope, anxiety, lightheadedness. Another thing to note is stable angina is reproducible and has short duration. It's often exacerbated by exercise, relieved by rest or nitrates. Acute coronary syndrome is persistent or worsening chest pain, not relieved by rest. So, provoking factors of these conditions are exertion, stress, cold exposure. Alleviating factors are rest and nitroglycerin. Cardiovascular disease risk factors include hypertension, dyslipidemia, diabetes, smoking, obesity, family history, usually in your immediate family, either on your mom or dad's side, or siblings, and age and male sex. These are non-modifiable risk factors. And then classic angina triad, these are the three symptoms that make these conditions more likely. So substernal chest pain or pressure, worse with exertion, or relieved by rest or nitrates. These are the symptoms and their likelihood ratio of how likely it is that these symptoms are evident of these conditions. So pleuritic chest pain is a low risk symptom, makes acute coronary syndrome or stable angina less likely. Syncope is also not associated. So intermediate risk factors such as radiation to the left arm, neck, or jaw makes makes it more likely. Pressure sensation, sweating, diaphoresis, or exertional chest pain. If it's constant throughout 24 hours or comes in and out, comes and goes, then it's more likely high risk symptoms. So if they had a previous myocardial infarction and these symptoms are similar to the prior event, then it's more likely. If they have a comorbidity of peripheral artery disease, if they have pain that's radiating to both arms, or if they have abnormal prior stress tests in the past, these make acute coronary syndrome or stable angina more likely. So important to remember that women, elderly, and patients with diabetes mellitus are more likely to have less classical symptoms. So what does that mean? So when a patient is in the ED and complains of chest pain, it's very important to get an EKG ordered right away. Usually the ED physician will take care of that, but if they happen to not have one, make sure you order that immediately. And you can also order blood labs and troponins. So anti-anginals are nitrates. You can try this and see if the symptoms go away. You should avoid if preload sensitive. Remember, in a right-sided heart attack, basically the inferior portions of the heart are not being perfused. So if you decrease the preload, it can exacerbate the issue and you can have bradycardia and cardiogenic shock. Beta blockers you should also not use if they have any evidence of ischemic heart disease, such as acute decompensated heart failure, long PR intervals, or AV block. Calcium channel blockers you can use if they are not going to be if they're not going to be able to take beta blockers or ranolazine. So physical exam. So these are the things you should look out for if they if you're suspecting this is any signs of distress, so labored breathing. What does that mean? Accessory muscle use. So there's a particular way that patients will present if they have this is like they're essentially tripoding or using their intercostal muscles, and you see their rib cage do excessive movements while they're either lying supine or seated. Diaphoresis, so sweating. S4, which is diastolic murmur. Basically, S4, the way I remember it, is pressure overload. So you have this in the evidence. There's any diastolic heart failure. Mitral regurgitation, congestive heart failure signs such as crackles, plus S3, increased JVP, and pedal edema. This is basically signs that patient is having signs of cardiogenic heart failure. Any signs of carotid, subclavian, or abdominal bruit, which indicates that they might have peripheral artery disease. Bilateral femoral and radial pulses, less likely it's less likely they have ACS if they have pleuritic pain, positional pain, or reproducible by palpation. All right, let's talk about acute aortic syndromes. So basically, these are conditions like abdominal aortic aneurysm or aortic dissection, or abdominal aortic dissection, or yeah, things of that nature. For history, you should ask if they have any acute or abrupt onset of tearing or sharp thoracic or abdominal pain. Risk factors that make this more likely if they have any known aneurysm in their prior medical documentation, if they have Marfan syndrome, it's basically like a collagen disorder, which makes aneurysms more likely to be formed. Any connective tissue disorder like Ehlers-Danlos, there's a couple other conditions, Menkes disease and stuff like that. That also makes this more likely. Hypertension, so if you have persistent hypertension, it also makes it more likely that you have connective tissue disorder and the problems with the structural integrity of the vessels. If they're men, they're more likely to have this. If they're 60 to 80 years old, they're more likely to have this. If they have any prior current cocaine use or any high intensity exertion, weightlifting. Also, something that's not mentioned here is smoking. So if they're smoking and they've smoked for at least a couple years, they're more likely to get abdominal aortic aneurysm and acute aortic syndromes. So physical exam findings, if you have these conditions, there will be blood pressure variation greater than 20 millimeters mercury between arms. Any pulse deficits, so you're like weak pulses in the radial or uh, dorsalis pedis pulses. So another thing to go into physical exam a little bit. So you can use different pulses. I typically do like radial pulse bilaterally, and then I'll do the carotid pulse, and then I'll do like the dorsalis pedis pulse. That's usually next to your first phalange, and I'm not sure if I could describe it adequately, but it's essentially proximal to the first phalange and more medial in between the first and second digits. And okay, so anyways, if they have any new diastolic murmur, so S4 or yeah, something like aortic regurgitation or yeah, like mitral stenosis, focal neurological changes. So any focal neurological symptoms such as confusion or altered mental status, or loss of sensation, or motor control. Okay, acute pericarditis. What is the etiology? So basically, there's some type of inflammation in the pericardium, either idiopathic, viral, or inflammatory. You should ask stuff like any pleuritic chest pain that improves when they lean forward. Do they have any recent history of upper respiratory infection? Any rheumatologic history or symptoms such as like lupus or like sarcoidosis and stuff like that? Consider bacterial if they have high fevers that's not responding to anti-inflammatory medication. And physical exam, there will be a friction rub. So this is basically like a scratchy sound that you can listen to in the fourth intercostal space on the left. And if there's any signs of tamponade with pulsus paradoxus greater than 10 millimeters mercury, what does that mean? So like basically when a patient holds their breath, does the blood pressure change by greater than 10 millimeters mercury? And okay, let's go into the next condition. So pulmonary embolism. So pulmonary embolism is basically a thrombus that dislodges usually from the proximal femoral vein or in the lower extremity that dislodges and goes through the IVC and then eventually makes it into pulmonary circulation and then blocks off uh, a segment of the lung from being perfused. So the history, so you'll have a sudden onset of chest pain, difficulty breathing, dyspnea, hypoxemia, or pleuritic chest pain. The risk factors are any history of cancer, any recent surgery, any immobility, any hemoptysis or blood when coughing, any calf, thigh pain or swelling in the lower extremities, could be in the upper extremities as well. Physical exam, so you'll have tachycardia, tachypnea. Tachypnea is basically like increased rate of breathing, hypoxemia, calf, thigh erythema and swelling, any tenderness, any signs of right ventricular strain. So this right ventricular strain is actually really important when you're looking out for pulmonary embolism. So basically, if they have any evidence of right ventricular strain, this will be on the transthoracic echo, and it'll show like decreased mo wall motion in the, I think it's a right heart. So if that's the case, then I think it requires more intensive management, but that's a topic for a different video. But basically, that's how you know to rule it in. Pneumothorax. So pneumothorax is essentially part of the lung that's collapsed. So this can be either traumatic or atraumatic, or could be like spontaneous. What else? Yeah, there's different types of pneumothorax, but essentially part of the lung is collapsed. And the history, you should ask if they have any sudden onset, difficulty breathing, or dyspnea. Risk factors are if they're 20 to 40 years old, more likely if they're tall, family history or personal history of pneumothorax in the past, any smoking history, any known emphysema. Men are more likely to get this condition, and any recent chest procedures or lines. Physical exam, so if they have any ipsilateral absence of breath sounds or contralateral deviation of trachea, that's sign that it's likely pneumothorax. So actually, their physical exam will differ based on what type of pneumothorax it is. For example, if it's atelectasis, the trachea will actually deviate towards the lesion. But if it's pneumothorax or tension pneumothorax, the trachea will deviate away from the lesion. All right. So pneumonia and pneumonitis. So pneumonia, pneumonitis. So what is the difference? So pneumonitis is basically ingestion of gastric contents or some type of acidic compound or just some type of injurious material that gets into your lungs and cause inflammation. Pneumonia could happen either independently or after pneumonitis. So basically, pneumonia is development of infection in the lung. And so, what type of question should you ask in history? Is there a sharp pleuritic pain, chest pain associated with fever or leukocytosis or elevated blood leukocytosis, basically elevated blood count, productive cough, recent radiation, any autoimmune conditions such as SLE or drug-induced lupus, collagen vascular disease? So, a physical exam. Do they have bronchial breath sounds? That just means like crackles, essentially. And is it dull to percussion? And okay, and other causes of chest pain. So other cardiac causes of chest pain could be trophic obstructive cardiomyopathy or HOCM, aortic stenosis, a vasospasm such as Prinzmetal angina or vasospastic angina from a drug or toxin, Takotsubo cardiomyopathy, which actually generally happens in elderly women, but can happen to anyone. It's basically like a surge of catecholamines, which causes systolic abnormalities of the left heart. So then you have MSK causes, such as costochondritis, zoster, and zoster. So like costochondritis is actually one of the most common causes of chest pain. So usually patient will have some type of like rib fracture or like some type of trauma to the chest. They could just be a weightlifter when like they present in the clinic with chest pain. If they're younger, makes costochondritis. But basically, if you're able to reproduce the chest pain, like you press on their chest and they have pain, that makes more concerning causes of chest pain less likely. It's usually costochondritis. All right. So GI causes of chest pain could be GERD. So GERD, you'll have regurgitation of gastric contents, which can sometimes present as chest pain, esophageal spasm, so they'll usually have difficulty swallowing and will usually complain that, yeah, they feel like stuff is stuck in their esophagus. Boerhaave, that's basically after Boerhaave and then Mallory Weiss. So this is basically when patients have been vomiting for a long time and they either have transmural or I forget, it's like transmural or mucosal ulcerations of their esophagus. So, not ulcerations, tears in their esophagus. So, basically, if you vomit for too long, the retching can cause tears in the esophagus. And a Boerhaave is transmural damage. So, that could be causing chest pain. Peptic ulcer disease. So, it could be a gastric or duodenal ulcer. So gastric ulcers are improved. No, gastric ulcers are worsened by eating. Duodenal ulcers are improved by eating. Biliary colic, if you have problems with your gallbladder, it can basically present as chest pain sometimes, and especially when eating fatty foods and things of that nature. Pancreatitis, so pancreatitis, if they have any signs of trauma or epigastric pain radiating to the back, leukocytosis and elevated amylase and lipase. I forget the signs, but it's basically like when you have a subdermal hemorrhage of the skin in your epigastric region, that's also signs likely pancreatitis. All right, psychological causes of chest pain, like panic attack, if they're breathing rapidly, if they have any psychiatric disorders, could be likely, but you have to rule out all the other causes. So let's talk about basic chest pain algorithm. So this is the algorithm here. I kind of wrote it down in text format. I'm just going to talk about this, but you could pause and then take a look. But yeah, essentially, you get the EKG first, and then if they have any positive features of the following conditions, then you work that up. So, for example, if they have pericarditis, they will have diffuse upsloping ST elevations or PR depression and PR elevation in the AVR or increased CRP, you work in pericarditis. If they have greater than or equal to zero point 0.5 millimeters ST depression or T wave inversions, it makes N STEMI more likely. A STEMI is more likely if you have greater than or equal to 1 millimeter ST elevations in any two consecutive leads compared to the prior ECG or new left bundle branch block. You order plus or minus, so you order high sensitivity troponin. Non-invasive tests can be done if stress test or coronary CTA. Angiography, so you can do angiography if you're suspecting STEMI or high risk NSTEMI. All patients with confirmed acute coronary syndrome should undergo angiography. You should use the Grace, TIMI, or HART scores and Mayo Clinic score to calculate the risk of cardiovascular event. And this is a calculator you could go on MDCalc, figure that out. I think your attending would want to hear that. All right, so pulmonary embolism, if you suspect this, they will have sinus tachycardia, I don't know what the RADS means, but a new right bundle branch block, T-wave inversion, and T-wave inversion V1 through V4. S1, Q3, T3, suggestive of right ventricular strain. You get the POCUS echo and trans transesophageal echocardiography. And then if the history and physical is non-diagnostic, just get a chest X-ray. If it's normal, you order the POCUS echo, CTPE or CTA. If pneumothorax is evident on this chest X-ray, you do needle decompression or chest tube. If pneumonia is likely, you treat with antibiotics and decide if they're being managed inpatient or outpatient. You typically use a curve 65 criteria for that. And then widened mediastinum, so then you can rule in stuff like aortic dissection and order CTA. But that's chest pain. So, all right, I hope that helps.